speaker is Dr. Shweta Mehta. And I would say that, we are very lucky and fortunate that we have a specialist with a different kind of viewpoint and vision. Typically, if there are any situations where you need help with a specialist, you are seeking help when they are in a late stage of their disease process. Dr. Shweta Mehta brings a new perspective because she's focusing on the early aspect. She's focusing more on prevention. She has done she's a clinical biochemist. She has done her degree in UK. I'm not even sure if we have this kind of designation in Canada or US. I'm not familiar with it. Her focus of interest has been in weight management. As you can appreciate, that obesity is the root cause of many of our problems, whether it is diabetes or hypertension or cardiovascular disease. She has a focus on cardiovascular risk stratification and reduction. She also has focus on pre-diabetes management and renal stone prevention. So for any metabolic issues, she is our go-to person, and we are very fortunate that she's practicing in our community. With her, I would also like to invite Ms. Jenifer Tharani. She is the registered dietitian. As you can imagine, any weight management program or metabolic program cannot be successful without a dietitian. So she's part of the team with Dr. Mehta, and she has done her training from Texas State University and dietitian training from Emory University in US, and her special interest is again in weight management, diabetes, and she also touches a niche area of gastrointestinal disorders, whether it is celiac disease, IBD, and kidney disease. I would like to welcome Dr. Shweta Mehta and Jenifer for this presentation.
But I think before dinner is probably good, so yeah. Okay, so, sorry, this is very wobbly. All right, okay. So we chose this talk because there are a lot of misconceptions or even true ideas in not only the minds of the patients, general public, but also as us physicians. So we thought we would address some of the facts and some of the misconceptions associated with obesity and weight management. We have no disclosures or conflict of interest. So the learning objectives are that at the end of this session, the participants will be able to understand factors involved in pathophysiology of obesity, identify role of lifestyle modification programs that are effective in weight management, and recognize the importance of pharmacotherapy and other treatment modalities in order to provide a cohesive approach. So that's going to be the bottom line. So why do we want to talk about obesity? Now, WHO data from 2016 showed that nearly 40% of adults worldwide, they are overweight, and another 13% are obese. In Canada, every 1 in 4 individual is obese, and 1 in 9 has class 2 or class 3 obesity. But that's just, we're talking about the size. What about the impact on health? Obesity is associated with a number of diseases. It increases the risk of a lot of diseases. You think of a system, and obesity has some role to play in that system. So it increases the risk of diabetes, sleep apnea, cardiovascular disease, major depression, osteoarthritis, and not to forget gastrointestinal effects, increased risk of gallstone, fatty liver disease, impact on fertility, sexual dysfunction, and also association with a lot of cancers, including colon cancer and breast cancer, to mention a few. So here are 2 statements I want everyone to think about. How many of us here think that obesity is a behavioral disease? Can you raise hand who think obesity is a behavior disease? No one? Oh, maybe a few. Okay. And how many of us think that individuals who are obese do not have enough willpower? No one. All right. So we are in consensus there. And this is what I want to highlight here. There's a misconception And that's just something when I see an obese patient walking through my clinic door, I'm like, okay, so he's going to have probably all these things, and I'm going to say, please go and lose weight and you'll be fine. So for pathophysiology of obesity, we have to look at many factors. Now, how many of you actively manage patients with weight problems? So all of you. And what are some of the things you ask the patient when he or she comes to you to find out what could be causing the weight issues in this patient? What are some of the things you ask? Diet, excellent. Exercise, yes. So lifestyle, anything else? Any medications? Yes. Thyroid symptoms, yes. So we are trying to find underlying metabolic disorders. Family history, wonderful, thank you. So yes, so if we look at pathophysiology of obesity, there are a number of factors. Genetics, family history plays a very big role. So if you have born in a family where there are people who live in bigger bodies, chances are you have inherited similar genes and you will be also living in a bigger body. There are lots of biological causes. Yes, we mentioned some of them. Underlying diseases, underlying metabolic problems, medicines. Certain biological states, for example, post-pregnancy, post-menopausal women, they all tend to put on weight. And then behavior. Behavior is a big thing, but it's not the only thing. Yes, diet, lifestyle, sleep, stress. And of course, I have written here socioeconomic and cultural factors. How many of us ask that?
When the patients are poor, they eat a lot of fast food, like McDonald's, and
Yeah.
cheap, $2, $3
Yeah.
meals.
Thank you, Dr. Kapoor. Yes, that's exactly the point. So socio-economic and cultural factors play a big role. Cultural, also the kind of what their cultural diet basically is. Now, before I go into pathophysiology, let's all imagine ourselves here. So we all came from our works. We were all very hungry. So there was these signals going in my body. Okay, I'm hungry. What's that signal? That's ghrelin from our stomach, going to the hunger and satiety center in the hypothalamus, triggering off some neurons saying we want food. Okay, so we got some food, we got our appetizers. Now what happened? Now, there are other things which were secreted in our intestine, hormones like GLP-1, CCK. There were vagal symptoms which all went back and said, okay, this food, we can the hunger can be suppressed now, and we are feeling full. But we're still not totally full. Now, soon we'll have our dinner. And so these are the peripheral signals I just talked about, so gastrointestinal. And of course, there are lots of signals from adipokines in the fats, which manage how the fat stores are mobilized in the body. Okay, so now we have had our food. We have all had, okay, let me give another example. I've had my dinner. Now I'm sitting on the TV, watching TV in front of the couch, and I'm like, oh, I need some ice cream now. Maybe I should have some chocolate. So I'm full, but I have still some cravings. So there's another system in the body which is coming into play. This is what we call as the reward system. It's the mesolimbic system. And what it does is, it creates that food cravings. So even when you're full, even when our hunger system is suppressed, we still have these cravings. Okay, now should I have that chocolate or should I not have that chocolate? That's the question. Okay, I'll have a chocolate, but should I have just a small bite or should I have the whole bar of chocolate? Maybe I'll have it today. Maybe I'll not have it tomorrow. Maybe I'll have a little bit every day. Doesn't matter. So we start in thinking this way now. What's not triggering? This is the executive decision-making portion of our brain, which controls all the cognitive functioning, and that is the frontal lobe. So simply from being just food and exercise, now we have realized there are lots of higher functions which control our appetite and food regulation. Add to it hedonistic responses, our conditioning, how we have been conditioned throughout, whether it's sight, smell, taste, or even thought of food. They make us hungry. They want us to reach out for food. And a lot of subconscious and mindless behaviors which make us seek out food. And last but not the least, then it's the adaptive mechanisms of the body. So the body always tries to maintain weight around a set point. That's the homeostasis. The temperature was very cold in this room. Most of us started shivering. Could we stop it? No. In the same way, Anytime you try to control your hunger, you try to lose weight, the body's adaptive mechanisms kick in and they try to restore the weight to original level. And that's why it becomes very, very difficult for patients to lose weight because it's now no longer a disease of behavior. It's no longer a disease of willpower. There's so many things involved now. So I'm not going to go through this web, but this just summarizes what I have told now. So we have peripheral signals, we have central signals, and we have all sorts of external stimuli and a lot of subconscious, involuntary stimuli and responses as well, things which we cannot control. So if we go back to these statements now, is obesity a disease of the behavior? No. Is obesity a disease of the willpower? No. There's so many other factors involved. And in words of Zeng and Berthold, I really like this saying. They have said it specifically in terms of obesity, that although humans have the ability to make a conscious, voluntary decision and choices, most of our actions have a subconscious component which is out of voluntary control. Now, how do you measure obesity? It's by body mass index. We are all familiar with this. We are familiar with the classes. But body mass index just tells us how big a person is. It does not tell us how healthy a person is. And that's one of the main disadvantages of using body mass index, but this is the best we have. So this is not very visible from far, but it's Edmonton obesity staging system. How many of you have seen this before? Okay. So this was designed by Professor Arya Sharma from Edmonton, and it takes into account not just the size, it also takes into account the impact on physical health, psychological health, functioning, and quality of life. And it's divided into different stages from 0 to 4 based on how much worsening there is in each of these categories. Okay. Interventions for weight management. We'll start with lifestyle management. I would like to call upon Jenifer, who's our dietitian, to take the stage now, and then I'll join her later to talk about some more interventions.
Thank you, Dr. Mehta. So I'll be talking about interventions for weight management. Oops. So the first one is dietary strategies. We all talked about, you ask your patient, the first thing, diet is what do they eat? So dietary strategies for weight management include low-calorie diet. Everyone is familiar with that. Recently, the keto diet has become very popular, which is low-carb, high-fat. And other strategies are low-carb, high-protein diet. Some of the dietary patterns-based dietary strategies include Mediterranean or DASH diet with energy restriction. So the bottom line or the key with all of these dietary strategies is caloric restriction to help your patients with weight loss. Meal replacement is another evidence-based strategy for weight management. It combines medical supervision, education on lifestyle modifications, and meal replacement for an active phase followed by regular meals. Exercise. So exercise, the evidence doesn't support that exercise will help the patient lose weight. However, it's very, very important during the weight maintenance phase. And the last one is behavior interventions. So behavior interventions, when combined with dietary strategies and exercise, have been shown to help patients with weight loss. But it also helps prevent the patient from regaining weight because it builds the skill set in the patient that helps the patient to kind of engage in weight loss supportive behaviors. So I have this statement here. I would like for you to tell me if this is a fact or a myth. Some weight loss interventions are more effective than others in long term. How many? Raise your hands for fact. Great. And how many for myth? All right. So it's a fact. So when interventions focus on diet alone, let's say, for example, meal replacement or weight loss drugs with diet, the research study, what happens is these dietary strategies or help with weight loss initially, like short-term, we see short-term great results. However, the weight loss begin to plateau at about 6 months. in most of the interventions. So what plays an important role is the behavior management of in these patients. So a lot of these patients require long-term support through accountability check-ins and support group in addition to behavior management. So this is the evidence-based study that looked at intensive lifestyle intervention. So as you'll see, 38% of patients in the intensive lifestyle intervention, which included meal replacement, education, behavior intervention, as well as long-term support for 8 years, lost at least 10% of their body weight in first year, and 27% maintained the weight loss. This is another statement. Meal replacement program is an effective weight management strategy. Give me a raise of hands who think that this is a fact. Great. So it is definitely a fact. There are certain studies that have been done, such as Optivin study, which showed that patients on full meal replacement lost twice as much weight as at 26 weeks as well as 52 weeks compared to those patients who were put on calorically restricted food-based plan. The other incredible study that was done is called Direct study, in which 46% up to half of the participants who were in the intensive weight management treatment arm received meal replacement as well as diabetes education, were at diabetes remission at year 1 compared to only 4% in the control who did not receive the meal replacement. Again, exercise is a critical component of weight loss intervention. Is this a fact or a myth? So it is a critical component. The experts recommend 150 minutes of exercise, moderate exercise that includes cardio and strength training, especially during the weight maintenance phase. Another. And not even that. Actually, it will only help you maintain the weight you have lost, not even help in weight loss per se. Dietary and exercise education alone makes weight loss intervention successful. Is this a fact or a myth? Who's up for myth? All right. So definitely it's a myth because there was... when we do only behavior intervention, where we teach patients about self-monitoring, goal setting, removing stimulus, problem solving, that does help in addition to dietary strategies. However, recent research has shown that poor long-term weight loss outcomes are due to lapses in adherence in weight loss supportive behaviors. So another tool has come out in recent research, which is called acceptance-based therapy. So the Mind Your Health trial supports the use of acceptance-based therapy, combining it with standard behavior therapy. And according to this research paper, this acceptance-based therapy works really well if you have patients who have depression, who are prone to emotional eating, or who have heightened responsivity to their obesogenic environment. And the study found that participants who received ABT versus SBT were likely twice as much able to maintain their weight loss versus the ones who only received standard behavior therapy. Lastly, I'm not sure how many of you have heard of this or used this in your weight management practice, but intuitive eating is an anti-health and anti-weight management approach because it promotes you can eat whatever you want whenever you want. Is this a myth or a truth? Or fact? Who's for the myth? And who's up for the fact? Okay, we have 50-50. So it's a myth, actually. Intuitive eating is an evidence-based tool used by dietitians, especially for the weight maintenance phase. It helps to tune in. So Dr. Mehta really did a good job explaining that you were hungry, you ate, so you tuned into your hunger signals, you stopped eating when you were full and satisfied. So that's what it does. It teaches patients to kind of tune into their internal cues versus rely on external cues, such as timing of the day or triggers or temptations to start eating or stop eating. So now I'll hand over to Dr. Mehta.
Thank you, Jenifer. So after lifestyle interventions, I want to talk about pharmacotherapy for weight loss. A lot of people still believe that medicines for weight loss should only be offered if lifestyle has been unsuccessful. Do you agree with me? No. So we have a general consensus there because the thinking now has changed. Now, obesity is considered a chronic disease. Just like as you would do in diabetes, just like as you would do in hypertension, if you have a disease, you will treat it. So not just lifestyle interventions, we need to offer pharmacotherapy as a first-line intervention, even for weight management. In Canada, orlistat, liraglutide or Saxenda as we call it, and naltrexone bupropion combination or Contrave. The mechanism of action for orlistat is it's a pancreatic lipase inhibitor, so especially useful for those who eat high-fat meals because that also becomes a side effect and puts patients off their fats. Liraglutide is a GLP agonist, so it works on the hunger center. Remember, lots of GLP from the intestine when you eat goes to the hunger center and suppresses it. And the naltrexone bupropion works on the rewards or the food craving system. Most of these drugs are well tolerated. Some of the patients do experience gastrointestinal side effects, but otherwise usually well tolerated. Just with Contrave, we have to be careful for patients who have a history of seizures or who are taking opioids because naltrexone is an opioid antagonist. I'm not going to go into details of the trials of these drugs because all of these three drugs, they have been shown to be very effective for weight management. So this is a result from a meta-analysis where all these trials were put together. And what they showed was liraglutide was most effective. More than 60% of patients who were on liraglutide were able to lose 5% body weight at least. And we know even losing a 5% body weight, it is associated with good health outcomes. And even they were also able to lose 10% in about 34%, and quite similar results for Contrave, though slightly less. And again, orlistat was quite effective. Not only weight, these drugs also have effect on other metabolic parameters because we say obesity and all these metabolic disorders go hand in hand. So yes, tremendous effects on glycemic control with all of them. And also some effect on lipids. But Contrave or naltrexone bupropion combination is slightly unfavorable for those who have high blood pressure. And that's one of the things we tell patients, like if your blood pressure is not stable, I usually not use it because it can precipitate uncontrolled hypertension. I often get asked, how long do I have to take this drug for to help me lose weight? And again, I say the same thing. If you had diabetes, how long would you take this medicine for? If you have high blood pressure, how long would you take it for? Probably a long, long time. Unfortunately, as far as evidence shows, we have very limited data on long-term efficacy of these drugs. There are some studies which have looked at about 2 to 4 years data post-starting, and they say that at least 2 to 4% of the weight loss is maintained with these. Liraglutide was most efficacious. And what happens if patients stop drug? There is some net weight loss, but as I said in the beginning, the body homeostasis kicks in. So weight regain is inevitable, and it happens. So if we look back at our statement, the misconception that medications for weight management should only be given after the lifestyle interventions have failed, no, they should be given along with lifestyle interventions as a first line. I'm not going to go into details of bariatric surgery, but there are currently 3 which are available to our patients: gastric banding, gastric sleeve, and Roux-en-Y bypass. The latter 2 are more common. And the details of these can be found on the Ontario Bariatric Network, which is a network of 12 centers dealing with medical and surgical management of weight issues. I want to just spend a couple of minutes more talking about behavior therapies, and then I'll wind up. So we've talked about medicines which affect the hunger and the reward system, right? But what about that executive decision making, the frontal lobe, which decides what to do? And that's where cognitive behavior therapy comes in. So that's one of the areas where we are really picking up lots of principles, and we are trying to apply them even in our weight management practice. So Jenifer and I are working on this. And of course, as Jenifer mentioned, acceptance-based therapy and mindfulness are very important components of weight management. So really, what can we do as physicians? I think first of all, what we have to do is remove that stigma and bias which is associated with obesity. We should not have any preconceived notions that anytime we see a person in a bigger body walking through a door, okay, the root cause of all the problems is weight. And then set smart goals with your patients. You have to be very clear about your expectations. I have ladies coming to me saying, "Doctor, it's my son's wedding in 3 months. Can I please lose about 20 kilos? I want to fit into that dress." And that's not a realistic expectation. So we have to identify what their best weight is. Now, best weight is very different from what an ideal weight should be. Best weight is where they are healthy and they are able to function properly. It may not be what their ideal BMI should be, right? Offer support, provide them resources, and stop telling them lose weight and you'll be fine. Instead, proactively help them to lose weight. I think that's very important. And long-term support. These patients need a long-term support simply because I said when they go off your clinic or they go off a diet, that's when the weight regain kicks in. So you have to provide them all the tools, all the support necessary to keep that weight away. So if there's one message you take from this today, it is weight management is not just the number on the scale. It's not how an individual looks in the mirror. Instead, emphasis should be on health, quality, and function of life. Thank you. Function and quality of life. Thank you.
Dr. Mehta and Jenifer for an excellent presentation. If somebody has any questions, please feel free to write on their question cards and pass it along. We'll be collecting them. The first question I received is this. Is it true that some patients cannot get below a certain weight no matter what they do? Some patients think that it is a fact that this is their weight, they cannot go below a certain weight.
That's not an easy question. Okay. So yes, it happens to some patients. They cannot go beyond a certain weight because remember, I talked about weight regain and body's adaptive mechanisms, they kick in. So what can we do to help these patients? Again, the same ideas. We have to provide them long-term support. We have to look at, okay, if this strategy is not working, these are the other options available for you. For example, okay, just lifestyle's not working. That's why I said, try and offer all the strategies at once. So, okay, we have a pharmacotherapy, we have a meal replacement therapy, we have a group therapy, we have a proper support, or shall I say, lifestyle-based therapy for you. So offer them, see what works for them, and you can always change, you can always combine, and it's never about one intervention. It's about multiple interventions, multi-prong attack at once. But you're right, some patients may still not reach that ideal weight. And that's why I said the concept of best weight comes in, where they are feeling healthy. They may not be at their ideal BMI, but they have a good quality of life.
Thank you. Jenifer, do you have anything to add to that?
No, actually, Dr. Mehta did complete the answer.
For Jenifer, what is meal replacement?
So meal replacement is basically, there are 2 options. One is full meal replacement, in which patients usually will do like 12 weeks of full meal replacement, where all their self-prepared meals are replaced with a shake. That's just the active phase to put them into caloric deficit. And then we transition them to the transition phase, in which they only do 2 shakes per day and 2 self-prepared meals. And then we transition them to self-prepared meals with structured meal plans. Throughout this process, there's also a lot of education, a lot of accountability, support, smart goal setting. And in the partial meal replacement, the patient directly will start with 12 weeks of 2 shakes per day and 2 self-prepared meals, and then transition to regular meals with structured meal plans that are calorically deficit based on the calculations I as a dietitian do.
Okay, so basically what you are saying is that these are set calorie based powders which can be made into shakes, and the patients drink it 3 to 4 times a day or 2 to 4 times a day for partial or full meal replacement, and then that can lead to net calorie deficit and weight loss. Yes. Some of the options, such as medically approved options, are something like OptiFast, which some of the clinics offer. And the next question I have is for Dr. Mehta. Is there ODB coverage of the anti-obesity medications?
No. And that's like one of the big challenges for all the, I should say, health professionals who deal with obesity management. There's no coverage for obesity management. The personal insurance, medical insurance may cover a part of the costs, but even the companies do not give any compassionate medications or samples. Yes, you were saying something. Pardon? Okay, so I'm coming to that, yes. Thank you. But the true drugs, Contrave and Saxenda, they have their own plans. So if you go to Contrave, you register with them, as Dr. has rightly said, they provide 20% off on prescriptions. And if you register with Saxenda Care, the patients get 50% off their first prescription. And then some pharmacies do them at a lower price than others. So,
The next question is, for you, Dr. Mehta, what is the effect of bupropion on people without any depression? What is the effect of bupropion on people without depression?
Okay. So bupropion, as we know, Wellbutrin, it's been widely used as an antidepressant drug in patients who do not have depression, and at the doses which are used in Contrave, they appear to not have much effect, but still, we always warn the patients about effects on mood and increased anxiety and maybe even suicidal ideation. So we have to warn the patients for side effects. But usually in the trials and other things they have seen, usually it doesn't, because the dose is not similar.
Okay. Jenifer, can you comment on cognitive behavioral therapy for weight management?
Definitely. So some of the ideas or some of the tools that are used by for cognitive behavior therapy is definitely self-monitoring. So when I generally see a client, I kind of ask them where they're at in terms of making sure that they're eating, quality foods. Are they incorporating snacks, things like that, just assessing the patient and then seeing where they're at and then helping them self-monitor. So basically set smart goals for them based on calories, based on the quality of foods, etc., whatever their needs are, and then help them kind of create keep the record. And then this other one is, we already talked about goal setting. The other one is removing stimulus. So changing their environment a little bit. So let's say if they have a lot of access to junk food at home, or if they're going through a route that always they pass McDonald's, for example. So kind of changing that stimulus and asking them if they're able to take another route, for instance, and see if that stimulus, removing the stimulus helps. And a lot of problem solving. So that's why accountability check-ins are very important, because every 2 weeks or every month the client kind of confronts a roadblock that kind of just prevents them from taking action, or they come across another idea for weight loss and then they have questions about it. So basically making sure that we are there for them in terms of goal setting, stimulus control, problem solving, and helping them monitoring their calories if we've put them in caloric deficit.
Thank you. And the last question for Dr. Mehta. Somebody mentioned Berenstein's diet clinics. Is it safe?
So there are so many diets these days. Dr. Bernstein's is just one of them. You look at the internet, there will be so many. I was amazed to see how many there were. There was liquid diets, and there were fish diets, and there were lots of diets. It depends the person you're talking to, right? If you talk to someone who strongly believes in keto diet, they'll say, yes, keto diet's the best, and they'll give you this much evidence to show why it is best, right? Dr. Bernstein diets, Dr. Poon's, essentially, if you look at them, they're just very, very low calorie diets, right? So you're restricting the calories tremendously. The advantages of these diets, as I tell my patient, is they'll help you lose weight, and you'll lose weight very rapidly. But once you come off, if you're not careful, you're not only going to regain what you lose, but you're also going to regain some more. So that's always the flip side of these diets. And therefore, I always advise, whichever diet you follow, doesn't matter. All paths lead to that ultimate aim, right? That's what we believe in. That's our philosophy. Religious philosophy. So anyway, so it doesn't matter what diet you follow, what path you take, whatever you do, all the studies have shown one thing, that it is adherence to the diet which will determine whether or not it's successful. If you can do a diet for rest of your life, go ahead. You're going to be successful. But if you're going to go on these yo-yo diets, then I'm afraid not. You're going to regain weight every time, every step, and your ultimate slope will be upwards, not downwards. Thank you.
Dr. Kapoor.
Bernstein diets, I just have an issue, especially with diabetic patients or patients with arthritis. They lose the weight, but when they're diabetic and if they have CKD, their creatinine really goes up. Sometimes there's electrolytes, potassium goes up, and most of the time nobody is monitoring that. So I do have an issue with these diets.
Yes.
I tell my patients to be careful. I mean, it's good if you're, in for surgery and you need to lose 10, 15 pounds before you can have your knee replacements. And as long as somebody's monitoring you for your creatinine and your potassium and all, if there's nobody monitoring, it can be quite dangerous.
You're absolutely right. You're absolutely right, Dr.
Thank you.
Kapoor.
Thank you. I think, to add to that, again, some of these fad diets, such as keto diet, those diets, we have short-term data, but long-term data is lacking in terms of their effects on cardiovascular disease and lipids and things like that. So what I recommend is that it should be a balanced diet, which has all the nutrients. It should be a calorie deficit diet. The keto diets, some people start developing GI upset after a few days. Constipation is a big issue. Intermittent fasting is also being used, and what I say is, it is basically the opposite of continuous eating, which is going on in this environment. So intermittent fasting works because it's a fancy name for eating the right way that we should all supposed to eat, and eat within like 8 to 10 hours during the day, and not constantly snack throughout the day and after dinner watching TV. So basically intermittent fasting is nothing new. It's the way people were supposed to eat. And that's, you don't have to fast for 24 hours. You don't have to fast for 36 hours. You can just eat 3 small meals, maybe 2 small meals with a salad in between and some protein, and be successful long term. So thank you.
Yep.
Thank you. I want to thank our sponsor AstraZeneca for bringing us together today, and thank you to Daryl for on behalf of AstraZeneca. Thank you, and I will give it to Dr. Vadera.
Thank you.